All right. So no relevant disclosures. I'm on a clinical events committee, but that doesn't impact this. So my aim this morning is going to be to accomplish three things. First, to encourage you to think about how you think about the indications for surgical intervention. I want to promote skepticism on your part of received knowledge. We are post-Renaissance individuals. Reject received knowledge and be skeptical of expert opinion. And I want to endorse individualized patient-centered decision-making in the choice whether or not to intervene on the ascending aorta. So, of course, the question that we have to ask is where do we draw the line for intervention on the ascending aorta? We're generally talking about aortic diameter because that's the best metric that we've got. And, of course, the simple answer to the question is that surgery is indicated when the treatment is less dangerous than the disease. And if we're too aggressive, we know that we will cause iatrogenic injury. We'll hurt more people than we help. We can argue about where that line is, but that line exists. If we replace everybody's aorta in this room, no one will have an aortic dissection, guaranteed. But most of you probably don't need that done. And most of you probably wouldn't volunteer either. So how do we answer that question? We need to know something about the operative risks. The risks of the treatment actually include both the operative risks and the long-term risk of whatever it is you do. So if you end up replacing that valve, that patient has got prosthetic valve disease and they bear that risk for their whole lifetime. The other side is actually much more challenging, the risks of the disease. It's hard to answer because of incomplete knowledge about the denominator, about asymmetric outcomes information, and the mixed natural history and interventional outcomes that we oftentimes look at as endpoints in these studies. Now, first of all, to use some of Lars' data, the aortic dilatation is very common in patients with bicuspid aortic valve. So at his institution, almost 2,000 patients with bicuspid valve, this paper published just a couple of years ago, 42% of patients with aortas greater than 4 centimeters, that being a number that many would argue is significant aortic dilatation. Half of those patients underwent surgery. They followed the medical and the surgical groups to look at long-term outcomes. Of note, about half of those patients had intervention on their ascending aorta, with notably an operative mortality less than 0.5%. So kudos to those colleagues at Cleveland Clinic. And others have reported very low operative risk as well. Northwestern, Yale, operative mortality rates of 1% or less. It's pretty hard to do better than that, especially when you're up against a disease like dissection, where the early mortality is as much as 50% before patients even get to the hospital. About 25% of all patients who get to the hospital with a type A dissection, if you look at all institutions, don't make it, and 30% or so require late reoperation. These are the data that show the immediate death rate. It comes from the Oxford Vascular Study. About half of patients don't even make it to the hospital. And you're all familiar with these data about the relationship between aortic diameter and risk of rupture or dissection. Now, the important thing here is that large aortic diameter helps you, but smaller diameter, maybe not so much. We're also all familiar with this. A significant number of patients dissect with smaller aortas. That's where the problem lies. How do we manage those patients? We don't spend a lot of time arguing about replacing ascending aortas that are greater than 5 or 5.5 centimeters. Still, you need the denominator to calculate the risk. We've talked about that before. The relevant question is not can dissection happen at a small diameter, but what's the risk? Remember, our initial diagram was balancing risks. The problem of asymmetric outcomes information complicates our ability to look at retrospective studies to tell whether or not we've helped. So if you have a more aggressive approach to aortic resection, look at dissection, no dissection, aortic surgery, no aortic surgery. Those are the potential outcomes that you need to know the answers to have a complete picture of the problem. We've got some idea of the patients who don't have aortic surgery and experience a dissection. That's what most of our literature is about, right? We know some about dissections that don't occur, probably less. This is where we lack the denominator. But this whole side of the equation is unknowable. We cannot know how many of the interventions did or did not prevent a dissection, right? It's unknowable. It's as unknowable as whether or not the TSA check prevented a hijacking of an airplane, because they're non-events. This is the asymmetric outcomes information that impacts us when we look at retrospective studies that look at more aggressive interventions for the ascending aorta. Now, here's an example of how that impacts us. So this is, again, Lars' data, recent data of the 2,000 patients. Only 2 patients had aortic dissections, and I could point to that and say, you see, the risk of aortic dissection is very low. My suspicion is that Lars would come back to me and say, well, that's because we intervened on the correct patients and we prevented those dissections. The truth is, it's impossible to know the answer to that, right? It's impossible to know. We can get some notions, some ideas, but you really can't prove one or the other. I would note, however, that if the risk of dissection is in fact 0.1%, then an operative mortality rate of 0.4%, as remarkable as that is, all of a sudden doesn't look so low. Low is a relative term. It's relative to the natural history of the disease. The natural history of the disease. That's the third problem. When we look at retrospective studies, especially of interventions or not, on smaller aortas, we tend to talk about aortic events. As soon as we talk about aortic events that include things like a decision to operate, we're no longer talking about natural history. We're now talking about an endpoint that's impacted by yours and my thinking. It's not all about the patient, it's also about us and how our attitudes have changed. And in fact, if you look at this Toronto study, which is from JAMA, a very recent JAMA study that I think is a terrific meta-analysis, if you look at the risk of dissection for moderately dilated aortas, in fact, in their meta-analysis, the risk of dissection was less among patients with bicuspid aortic valve than with trileaflet aortic valve. And we can get into a long discussion about why that might be and so on and so forth, and whether a moderately dilated aorta is more or less dangerous when associated with a bicuspid valve. But remember, the outcomes that we're looking at now, ever since DeBakey and Cooley started replacing ascending aortas, it's no longer quite natural history. And here's the evidence for it. Even though the risk of dissection appears less for bicuspid than trileaflet valves, the likelihood of an operation for a moderately dilated aorta is actually higher for a bicuspid than a tricuspid associated valve. Now, that disconnect, the mere fact that they're opposite directions, should give you a clue that when we mix those outcomes for composite outcome, it's fundamental thinking about composite outcomes. If 2 elements of your composite outcome are going opposite directions, that's not a good composite outcome. And that's true whether we're talking about PCI versus CABG, or arterial grafts versus venous grafts, or aortic interventions or not. A fundamental problem with composite outcomes. Is aortic surgery an appropriate outcome event? Now, some reassuring information, a nuanced approach. Again, recent data published in this month's JTCVS from John Eleftheriades and the group at Yale. They talk about their algorithm, which channels patients, including bicuspid aortic valves, in the following way. If you have a bicuspid valve with significant valvular disease, they intervened. But if you had a bicuspid valve and moderately dilated aorta without significant valvular disease, managed medically, the long-term outcomes were excellent. So that demonstrated that for that algorithm, the chances of definite, what they've called here, definite aortic death or complication for patients with smaller aortas, which is the blue line below 4, the green line is the highest, is above 5, and the red line is between 40 and 50. The chance of an aortic complication is low with that algorithm that we described. So that's a little bit encouraging. One of the pieces of work that we did, actually the Graham fellow did when he was at MGH with us, was to look at not just aortic diameter, but age, patient's age. Those of you who are students of Randy Greep's work will recognize this from Tatu Javonen's work many years ago, looking at risk factors for thoracoabdominal rupture. If you also add other factors in, like age, you get a more nuanced approach to what the risk is of an aortic complication. And you can create a patient-specific threshold. Now, it would be wonderful to also add into that hypertension, smoking, et cetera, and get a truly patient-specific answer, because after all, guidelines treat the mean. They talk about the average person. The patient that comes in to see you in the office is not the average person. The person who comes into the office to you has a specific set of comorbidities, et cetera, and needs a tailored approach. So that's my third objective, to encourage you not just to adhere to guidelines, not to blindly say, well, the guidelines say this, that, and next thing, but to nuance your approach. So 38 seconds late. I apologize. Thank you. Do you want to discuss, or do you want to have Tom just go right ahead?
Well, any questions from the floor or comments to Thor?
They're speechless. Why don't we let Tom?
All right, well, let's come back to you then, Thor,
Okay.
because I think there's some important issues. We've got some good presentations, and I think this will open the discussion.
Yeah.
And I think you brought up some important points that we really don't know when to operate on patients from dissection. I mean, the UPenn data shows dissection occurs at a small size. The IRAD data, we know that in our patients that we've done reimplantations, 1.4% developed dissection, the descending aorta that was normal size. And we've got John F. Tirardi's team presenting some more data too on descending and thoracos. I think we maybe need to look at rupture versus dissection. And we've got some exciting stuff that we'll be showing pretty soon on MRI, looking at proteoglycans as a risk factor also for dissection. We've got to look at different things than just size.
Yeah, that's a really important point. We use size because we've got it.
Yeah.
We don't use size because it's a good way to make the decision. It reminds me of that New Yorker cartoon where the drunk is looking for his keys underneath the lamppost down the street from where he dropped them. And the cop comes by and says, "Why are you looking for your keys under the lamppost instead of up by your car where you dropped them?" And he says, "The light's better here." That's why we use diameter, because we've got it, not because it's a good tool. Oh,
Great.
Robin does have.
So, given the fact that a lot of us have aortic clinics and we're following more and more patients, what's your regimen for surveillance?
So that's a great question, so I tend to see them get a CT scan again at 3 or 6 months to be sure that it's not it's not an active mode, then maybe a year, and then stretch it out from there, based on whether it's been stable or not. But I would tell you I don't have the data. Lars may have better data about what the right interval is for imaging. If it's the ascending aorta, the other point to be made is that if it's the ascending aorta, use echo. If you do enough CT scans on enough people, you'll give somebody lymphoma.
Yeah, that's a great question. And just to what Thor's point, we don't know the answer. If you look at the thoracic guidelines we put together, 2 of us were asked to address that question about follow-up. And most of the time we bring back patients 6 months and then yearly or every 2 yearly, and that's more or less what we said in the guidelines. But we don't have good data on when to do it, and I think John's work is really going to help us to sort of give us insights into that whole issue.
And of course, there's no guarantee that it's going to get larger before it dissects either. So the whole thing doesn't make sense. We need a different metric.
Great, thanks very much, Thor. So our next speaker will be Tom Gleason from University of